This conference will now be recorded.
All right, so we're going to do chapter 2, workforce safety and wellness. And then we're going to talk about medical legal stuff on the next chapter for chapter 3. Probably the most boring chapters in the entire EMT curriculum. However, probably some of the most important chapters that we have as well to cover, because we got to make sure that we are safe when we're entering these scenes, making sure that we are physically enough to do the job. And that doesn't mean just physical, but also mentally fit as well. There are a lot of factors in behind this, which we'll cover during the lecture. So some of our national EMS education standard competencies is with a medicine is the applies fundamental knowledge to provide emergency basic care and transportation. Just disease and the awareness of how to decontaminate equipment after treating a patient, especially more now than ever. Like I said, we'll cover more of this in detail. With COVID the way it is, this has become a whole different world when it comes to deconning and disinfecting an ambulance than we used to do. Assessment and management of how to decontaminate the ambulance equipment after treating the patient. Preparatory stuff, applying fundamental knowledge of the emergency medical services system, safety and well-being of the emergency medical technician, EMT, medical, legal, and ethical issues to the provision of emergency care. The next one is the workforce safety and wellness, standard safety precautions, which we'll talk about, scene safety, BSI. And that is something you guys are going to be hearing through the entire class when I say scene safety, BSI. And it's something that you also have to remember to do when you do your practical stations. That is actually one of your critical skills. And if you do not say that, they'll actually fail you on your station. PPE, and the amount of PPE now that we're currently wearing, stress management and how to release some stress and finding different releases and outlets, dealing with death and dying, the prevention of response-related injuries, prevention of work-related injuries, lifting and moving patients, which is its own chapter in itself, disease transmission, and then the wellness principles that are out there. So to take care of others, we must take care of ourselves. We need to make sure that we are appropriately taking care of ourselves, getting the sleep that we need, and things like that, making sure that we're physically and mentally fit for coming into work. If our mind is elsewhere and we're not having a good day, then maybe taking a mental day off just to relax is probably a better option. Remember that we need to be on our toes. We need to make sure we're prepped and ready to go to work. We are dealing with sick people, and even at the EMT level, there are medications that you can administer or help administer that literally could kill a patient if you gave it in the wrong scenario. Right. When we're doing this type of work. EMT training includes recognition of hazards for personal neglect, environmental and human-made threats, and mental and physical stress as well. Some general health and wellness information would be, obviously wellness is a state of complete mental, physical, and social well-being. And the state of wellness must occur at work and at home. Like I said before, can you guys hear me okay now?
Awful staticky, Kevin.
Interesting. Was it working well before we started?
Yes.
It was sort of fading in and out.
Right. Is that any better?
You're right. I can't. I wasn't here.
Is this any better now?
That's clear.
That sounds good. Yep.
Right. I got a little bit closer to my computer. All right, we'll try this now. I got the message as well, saying that there were some technical difficulties here. It must be the Wi-Fi going in and out. We're still getting quite a bit of snow outside. So So what I was saying before is wellness is a state of complete mental and physical and social well-being. So what we're trying to do is make sure that we are mentally and physically ready to do the job. We get called to people that are very sick, and even at the EMT level, we are allowed to assist with nitroglycerin. Nitroglycerin, being a vasodilator, can actually kill somebody if their blood pressure is not where they need to be. I mean by killing people is they vasodilate to the point where the blood pressure will actually drop to a lower number, to the point where they may not be able to return from that. So especially someone who's elderly. So again, we need to make sure that we're on the ball, on the game every time we go out the door. If you think you're having a bad day, or if you think that you need to take a day off, you're overworked, you're not getting enough sleep, then maybe having a day may be better off for you. You need to find that state of wellness, which must occur at work and home. What they're looking for is to make sure you have that work-home balance. You need to be able to come home and not have to worry about work. So I had a guy that I'm really good friends with that works at the ambulance service I work at, and he manages another one. He goes,
I lost you
he
again.
goes, Kevin, I don't come to work to work. And I'm like, what? What are you talking about? Work. Then you lost me again.
You're
You
back
guys can
now,
hear
but
me now?
you're still cutting out.
What is going on here? This happened last time too. I know some people just dropped out. I'm not sure why it's doing that. Let me see if this will work.
Yeah, like every time you stop the lesson, we could hear you again, but when you're doing the lesson, it cuts out.
Interesting. Let me try something else here. Stand by a second. I know we're slow recording, but we'll go with it. All right, is that any better?
Yeah, we can hear you.
Yeah, I could
It
hear
sounds
you.
better at the moment.
All right, is that any better?
Yep, you're loud and clear there.
All right. So I'm just going to disconnect that then, because that was pointless. Let's see. Hopefully more people will come back on. I don't know what happened here. So as long as it's working now, we'll continue going. So what I was saying before on the work-home balance. So what I had a partner that told me one time, he goes, if I have to come to work, then it's not the job for me anymore. I was like, huh, interesting. Like, can you explain a little bit more? He goes, I come to work to have fun. He goes, what other job can you come to work, punch in, get your chores done, and your truck checks done, sit in a recliner and watch TV and get paid? I said, good point. He goes, I come to work to have fun at work. That's what you guys need to have for a mentality. Just come to work to have fun, not come to work to actually work. And then when the call comes out, you're in a good mood, good spirited, and you can go out and handle these calls. And that's the kind of atmosphere that we want to make sure you have in any, whether it be a municipality, whatever it may be. Come to work to train, come to work to learn, things like that, versus coming to work just to work. If you come to work and say, I have 23 hours and 58 minutes before I go home, then maybe being there is not the place for you to be. You know what I mean? So it's one of those types of things where you got to come to work to actually to have fun. Other components of wellness, obviously protection from disease and hazards. And I can tell you right now, COVID has really done a number even for employment, people coming into work. A lot of people have left the job, and things are starting to calm back down. We're seeing a higher number of people applying to work again, which means that people are not going to be overworked anymore, being forced over and things like that. So a lot of stuff is changing. But protection from disease and hazards is something we have to do. Yes, we still have to wear masks. Yes, we still have to wear NVOs, N95s. We got to wear full gowns, things like that. It's still out there for the people that have the COVID, as well as other airborne and bloodborne pathogens that are out there. Proper nutrition. I can tell you flat out, if you eat fast food every single day, doing this job, and we expect you to be up and you're up for a full 24-hour shift, if you're not eating properly, you're not going to fare well with this type of work. Sufficient exercise. Please don't be the couch potato when you come to work and sleep all day long. Get up, walk around. Just doing your truck check and getting out and doing base chores, sweeping up stuff, that's pretty decent exercise. It keeps you moving. When you're working the next day, make sure you get enough sleep at night before you go into work. Be well rested. If you work a 24-hour shift, you've been up all day and up all night, go home and get some sleep. Right? Don't try to force yourself to stay awake. It's going to add more stress, become sleep deprived, and the next time you come back into work, you're not going to be at 100%. Refraining from tobacco, drugs, and alcohol. So interesting fact, where I currently work now, there are only 2 people that I know of that actually smoke. And there are only like 3 people that I know of that work there that actually vape. Other than that, it's pretty much a tobacco clean facility, which is pretty interesting compared to when I first started. And if you weren't a smoker, you were like the minority. Now smokers are like the minority now. It's interesting how it's changed over the last 20 plus years. Taking time to relax. When you go home, it's home time. Okay. When you're at work and you have a chance to sit back and kick back and relax a little bit, hit your feet. It's a huge difference if you can kick your shoes off, sit back in a recliner, and just chill for a little bit. Find time, find your downtime, get some rest. When you're home, same thing. And if you're at home, don't worry about coming in back to work. Turn your phones off if you need to. Just find time to relax. Why didn't that change? There we go. EMTs often work in stressful situations. That's a proven fact of the things that we come into. As an EMT, your role is to be prepared, anticipate needed resources of what you're going to need to get a patient out, control the scene, and then care for your patient. You have no idea what you're going to come into. And some of you guys have been in the fire service for a little while, have gone on some EMS calls, and when you show up to a scene, you've seen this flat out of how dangerous things can be, whether they be stage 4 hoarders and you have a small little pathway to get in, to patients that are very obese, that are on a second floor that weigh 700 pounds, 600 pounds, that can't get down the stairs, to tight stairways, to horrible driveways. We always have some of the worst conditions. All in all, though, your calm manner will calm the patient, family members, and bystanders. So you got to think of yourself as that duck on the pond, right? You're calm and cool and collective on top, but you're going 100 miles a minute underneath the surface where they can't see you. You've got to show that you're confident. I didn't say cocky, but confident in the job that you're doing. If you can show that you're confident and do your skills and do what you're trained to do, you will keep your patient calm, the family members will be calm, your bystanders will even be more calm as well. You show up ready to work, professional, ready to do your job. Stress is any event, thought, or action perceived as a threat. Regardless of how stressful the situation, you must focus on in this order: personal safety, scene safety, including safety of others, and then patient care last. If things are not safe and the patient is dying, then the patient dies. It sounds horrible to say, but your safety and your crew safety comes first. Right. So again, you got to make sure you take care of yourself and your crew before you go into your patient. If scene is not safe, scene is not safe, and you find the right people to make it safe. Whether that be fire department going in for a hazardous situation, to law enforcement taking care of some kind of domestic or any kind of issue like that. As far as strategies to manage stress, you want to minimize or eliminate your stressors. All right. Find an outlet. What do you do at home that will help you relieve stress? Right. You know, is it walking, taking a walk outdoors? Is it, you know, going out to dinner with your significant other? I mean, whatever it may be, find a way to eliminate stress in your life. Change partners to avoid a negative or hostile personality. Right? Management should be looking at this kind of stuff, and if they find that you and your partner are just not getting along, it's not working, we try to mix things up a little bit. Change your work hours if you need to. Some places, like where I work, we do 48-hour straight shifts. If it's just too much for you, there's nothing wrong with saying, hey, I want 2 24s. Or, you know something, overnights are not just for me, or maybe day shifts aren't for you. Maybe you like doing the overnights. So there are things like that you just got to pay attention to. Change work hours, change the work environment, maybe request a transfer to a different station. Maybe a change in scenery might help. Cut back on overtime. If you're working overtime, 72, 84, 100 hours a week, maybe you should cut back a little bit. Change your attitude about the stressor. Talk about your feelings. Yep, male and female, doesn't matter who you are. Talk about your feelings, what's going on. Seek professional counseling if needed. Do not obsess over frustrating situations. Yes, there are a lot of them that are out there. Don't obsess over them. Just sit back, relax, all right? Try to adopt a relaxed philosophical outlook. If you need to seek professional counseling, don't be afraid to go. As we know, public safety, police, fire, EMS, all right, have a high suicide rate. Okay, we've seen it. Most of us are probably on Facebook. We've seen the posts that come out, right? I've seen from junior firefighters to senior firefighters that have committed suicide because of something that may have happened at work or their home life because of the stress that's there. So find ways to relax and then seek professional help if needed. Don't be afraid because your family needs you at home and you need to help people. Expand your social support system. Develop friends and interests outside emergency services. When you come home, you shouldn't be listening to a scanner all day long trying to see what else is going on. If you like going out and going with a four-wheeler, getting out into the woods, then do so. You like ice fishing, then go out in the ice and ice fish. You know, whatever it takes. Just find something else of an interest that does not involve fire and EMS. Minimize the physical response to stress by periodically stretching or yoga. I'm not asking you guys to go to work and start doing yoga stuff. If you feel like doing that with a yoga mat, go right ahead. But periodically getting up, stretching, moving around, that's a good thing. Slow, deep breathing. Into your nose, out through your mouth. Regular physical exercise and meditation. Limit the intake of caffeine, alcohol, and tobacco. I can tell you, probably a lot of you guys probably drink a lot of coffee and things like that. I used to drink a lot of things that had energy, caffeine, and I have cut a lot of that out of my life, and I actually feel more awake and better now than I did when I was drinking those caffeine drinks in the mornings to stay awake. And I went strictly to water or some kind of carbonated water to make it think like it's soda, but it's really not. Eat nutritious foods. And that's something that you're going to want to do throughout the day, especially when you're at work. Physically prepare your body for stress. Exercise, relaxation, and sleep. And you want to make sure you get that uninterrupted sleep, what they call REM sleep. You want to get into that REM phase where you can actually unwind, relax, get the sleep that you actually need. One of the biggest things in private EMS, and I bring that up a lot because I worked it, I've been there, and I've worked for municipalities as well. Bringing your own food to work and cooking at work, not only does it save you money, but on top of that, it's healthier for you. Don't just settle because McDonald's is right around the corner, right? You'll find that you're actually spending more money on eating out than you are bringing food to work and cooking for 3 meals or 6 meals, depending on how long you're there for. So disease prevention. Know your family's health history and adjust your lifestyle as needed. Balancing work, family, and health. Rotate your schedule. Take time off. You really should never let your PTO banks max out. right? I've seen people that have done that before. Oh, I got 240 hours of vacation time. I just don't feel like taking time off. Take time off. Remember, when your banks max out, they stop giving you stuff, more time. So take time off that is needed. That's why it's there. Take time off, vacations, even if it's a staycation at home. Infectious disease is caused by organisms within the body. Right? Communicable disease can be spread from either person to person or species to another. Which is why, like, one of the communicable diseases that are out there being airborne is tuberculosis. And now we also have airborne disease of COVID as well. And there's all different strains out there. I'm not going to beat you guys to death with COVID. You've seen enough of it in the last couple of years. Infection risk can be minimized by immunizations. So getting your shots, flu shots, COVID shots, make sure you're immunized as well. Protective techniques. So NVOs, N95s, face masks, face shields, things like that. Wearing gloves on every patient contact. Dave, I just saw your message pop up. Duncan is life. You're not wrong though. And then hand washing as well. So when you're using hand sanitizer, it doesn't kill everything, okay? You want to make sure that you are taking care of yourself, washing your hands after calls, and things like that. We have the pathogens, contamination, and exposure as well. So some routes of transmission include direct contact, like bloodborne pathogens. Remember that blood can live on surfaces for up to 7 days, especially diseases that are there within the blood, whether it be hepatitis or something like that, HIV. Indirect contact with needle sticks. Yes, sometimes ALS providers leave needles around. They should not be doing that. That is actually can be a termination type of effect for certain people, for certain services. We want to prevent needle sticks, okay, because we never know where those needles have been. Airborne transmissions like sneezing, foodborne transmission, contaminated food like botulism, things like that. Then vector-borne transmissions like fleas, ticks, and whatnot. As you can see here. All right. So all EMTs are trained in handling bloodborne pathogens. We talk about this stuff all the time. Scene safety and BSI, body substance isolation. So we're going to be utilizing gloves. At minimum, gloves now and face masks. Used to be gloves only. Gloves, face masks now are part of our normal routine. So the CDC helped develop standard precautions for hand hygiene. We need to wash our hands. Personal protective equipment like gloves, gowns, mask, eye protection, face shield. And what I just mentioned there, that's your respiratory patient that you have now in the back of the ambulance. Because you have no idea if they have COVID, unless they tell you. So I know this is a question that just posed here. And it's actually going to bring up, I'm not going to mention who mentioned it because it was done in a private chat. But certain vaccines are mandated. And COVID vaccine in Maine is a mandated vaccine. If you do not have it, you cannot have an EMS license. That is something that has changed. So that went into effect, I want to say like the first of the year they did this. So if you hold a Maine EMS license, whether it be EMD license from dispatching up into paramedic level, if you work in a hospital, any kind of health person is required to have the COVID vaccinations done. New Hampshire does not require it at this point.
Yeah, but I know at my service, even though I'm not licensed yet, it was still required.
Hold on one second.
Steve and I just got a call.
I'm replying back to you.
Okay, thank you. Sorry.
All right, be safe.
Thank you.
That's probably why my phone is blowing up.
That'll be me at the end of the month because I have to work.
It happens. That's why I record all the lectures. So it helps out. All right. So we talked about this right here. Patient care environment, obviously soil patient care equipment, environmental controls, textiles, laundry, needles. So if it's a needle or a sharp object, they need to go into a sharps container. If it's a laundry type deal, if it's soaked in blood, it needs to go into a red bag. If it's got a little bit of blood on it, then it goes into a yellow bag or a trash bag of some sort to get laundered. As far as soil patient care equipment, certain equipment we can dispose of. A lot of services have gone to disposable equipment that they can just replace, and it's gotten a lot cheaper. But there are some equipment that has to be cleaned that costs a lot of money, and we need to make sure that we spray it down and clean it appropriately with the right kind of concentration. I can't tell you exactly what it is because every service has probably something different that they utilize, but they all meet a certain standard. And then obviously environmental controls as well. So electrostatic sprayers is one of the biggest things that's out there now to help with COVID on the back of the ambulances. Some special circumstances. Would be like patient resuscitation or respiratory hygiene or cough etiquette. If I have a patient that's coughing, I always tell them, please cover your mouth. I have no problem telling them that because you know what? It's helping stop the spread of disease. And now I just have them put masks on, surgical masks, since it's a common theme. Hey, do you have a mask with you? Nope. Okay, here's one for you. Please wear it throughout the call. Hand washing is the simplest yet most effective way to control disease transmission. Please wash your hands before and after patient contact, even if you wear gloves. So when you're at this, I'm not saying stop patient care and use the patient sink, all right? But you want to make sure that you take care of yourself and wash your hands at the end of the call. So before you clear the hospital, when you pass off the patient to a nurse, medic, MD, whatever it may be, wash your hands before you get back into the ambulance. If there's no running water, then use waterless hand washing substitute, hand sanitizer. So again, make sure that you, even if you use this, when you find a chance to wash your hands, then wash it as soon as possible. As far as gloves go, you want to make sure you wear gloves if there is any possibility for exposure to blood or bodily fluids. Wear gloves on every patient contact. We use nitrile gloves. There are latex out there, but we do not carry latex on an ambulance. Maine EMS has made it very clear that they are latex free, and all ambulances have to be latex free. New Hampshire is the same way. Everything has to be latex free in the ambulances. Removing gloves requires a special technique, which I will show you guys on our first in-class session that we do. Eye protection and face shield. This is becoming a lot more common now, but it protects our eyes from blood splatter, things like that. If you've got a patient who's bleeding out or has an arterial bleed, put something to protect your eyes. Mucous membranes in your eyes can cause disease transmission, right? You want to make sure that you're taking care of yourself. Prescription glasses are not adequate. So if you wear glasses, they can still get inside underneath your glasses and whatnot.
Hey, Kevin.
Yeah.
This is Nick. I had a quick question. On the ebook quiz, one of the questions asked, what is the minimum PPE acceptable for responding to a call? And I just answered gloves, but the right answer was gloves and a face shield or gloves and protective glasses.
Yep.
And I guess my question is that deemed now the basic minimum?
That's the standard.
That's the standard. Okay.
That's the standard now. Gloves and eye protection.
Yeah. Okay.
Yep. And
thank you.
But to add to that, Nick, though, too, is face masks. And again, National Registry updates their tests all the time. So if you see something that says, face shield or eye protection gloves and face mask, that might be the correct answer now because of COVID. So keep that in mind. That's all. Gowns are protection from extensive blood splatter. It also uses now for COVID protection. If you are in the possibility of delivering a baby, which is within the EMT scope of practice, so you may have to deliver a baby someday, you're going to want to wear a gown because they're very messy. May not be practical in many situations, may even pose a risk for injury, but gowns are available to you. With COVID patients, we should be wearing full gowns. Respirators, as you can see here, are barrier devices. What you're seeing here is a type of respirator or N95 mask. One of the biggest ones out there now is an Envo. I actually have my own. They go for about 80 bucks. And then all it is a replacement filter inside, which makes it a little bit cheaper in the long run. They sit better and they work really well for the COVID, any kind of airborne disease. Mouth-to-mouth resuscitation may also transmit diseases as well. So again, that's why we don't do mouth-to-mouth, and the AHA has kind of gotten rid of that as well. So what you're going to see now for any kind of infected patient or any patient, if you're doing a mouth-to-mask breathing, you guys can see this right here. Do you guys see the laser pointer on the screen? This device right here is called a OneWay Valve. So when you blow air through it to inflate somebody's lungs from mouth to mask, if they were to vomit into the mask, nothing can come back through into your mouth. That's what they call it. That's why they call it a one-way valve. Those are on all pocket masks now. So they have been for a long time. If you use these devices once, BVM for a bag valve mask or pocket mask, they are a one-time use. Please do not rewash them and put them back on the ambulance. Right? They're not very expensive. They're like $13 for a BVM. They're not super expensive at all. Right? Please dispose of them when you're done. Proper disposal of sharps obviously help avoid HIV and hepatitis. So we do not recap, break, or bend needles. Please do not stick them into the seat cushions. That's an old method of paramedics 20 years ago. All right? Let's not do that anymore. Do not recap them. Dispose them in a sharps container, as you can see listed here. So in the sharps container. As far as employer responsibility, there's no guarantee of 100% risk-free environment. Risk of exposure to communicable disease is a hazard of your job, so understand that. You get called to someone in COPD, respiratory distress. You walk in there with this a surgical mask on. You risk you get the risk of potentially getting COVID. Right? Just because they have COPD does not mean that they don't have COVID pneumonia. So know your department's infection control plan and follow it. Infection control plans are OSHA required. Every department has to have them. And when you do your orientation, you should know where they are and where to locate them. Infection control should also be part of your daily routine, cleaning your ambulance. When you come into work, your ambulance should be cleaned by the previous crew. If it's not, then make sure you clean your truck. Wipe everything down, make sure it's ready to go. After every call, mop the back of your ambulance out, spray it down with the electrostatic sprayer, clean equipment, get back in service. Right? It should be done at the hospital, because if you go back in service without cleaning it, oh, we'll just do it a little bit later, and you get another call, whatever may have been in the back of that ambulance may also now affect and infect your next patient. Immunity. Even if the germ reaches you, you may not become infected, which means you've built it. You may be immune to it. Preventive measures, we maintain your personal health and receive immunizations. Help build immunity. They have that for hepatitis B, hepatitis A. You can get the shot series. Hepatitis B series is actually a required, to obtain, or you can sign a waiver stating that you decline, so a declination form saying you do not want it. But it has to be offered to you at no cost to the employer. No cost to the employee, and the employer has to cover it. If you are exposed to a patient's blood or bodily fluids, turn over patient care to another EMS provider. Clean the exposed area, rinse your eyes if necessary for 20 minutes underwater. Activate your department's infection control plan. So a lot of times they'll have what they call a DICO, or dedicated infection control officer. They call it DICO, or just infection control. And you need to complete an exposure report and a workplace injury report because it's all coming under workers' comp. You're then going to go to a hospital, and then you can get blood work as well. And usually they'll end up testing the patient to see if they have any diseases based on the blood work that they pull. It does take some time, and they may start you on some kind of prophylactic medication as well to start the process in case there is something there. As far as scene safety goes, begin protecting yourself as soon as you are dispatched. So as soon as you hear the dispatch call, we're dispatched to report a motor vehicle accident over an embankment. You know it's snowing outside. You know it's going to be a dangerous type of call. Patient's still in the vehicle, reported to be unconscious. So we know we're going to have to get it stabilized. There's a lot of things need to be going through your head. How are we going to gain access to this car? Do you know the area that they're in? Continue to protect yourself once you're on scene. If you get on scene of a motor vehicle accident, and remember, we're talking about EMS, you have to have a minimum of a traffic vest. Some departments will issue you flash protection gear. Some will issue a full turnout gear for firefighting if you're doing a municipal cross-trained department. Either way, though, you need to protect yourself. Right? And then we start talking about stabilization and things like that for car accidents. If there is a scene hazard, identify what you see from a distance. Every ambulance in New Hampshire and Maine are required to have binoculars in them in the front. Right? So if you see a 18-wheeler flipped over with a tank on the back, and you see the number is 1203 on the back, we know that's going to be some type of petroleum fuel, right? We don't want to go anywhere near that. That's a hazmat situation. Okay, we got to stay away because any kind of spark could ignite, right? So we want to make sure we're not in an area that could be dangerous. And these are where the emergency response guidebooks come into play. They're good for about the first 30 minutes of an incident. After that, they might as well just be a wheel chuck. But the first 30 minutes can give you a lot of information out of this book, and also evacuations and things like that. We'll cover more of this in hazmat towards the end of special hazards. Electricity is beyond the scope of the EMT training. So we want to make sure we mark off a danger zone. And then if there's lightning, remember a repeat strike can occur in the same spot. Either direct hit or ground current is definitely possible. If you are struck by lightning, remember if electricity going to your heart does not like electricity. Therefore, it can put you into a lethal rhythm. Another thing to pay attention with as well is going to be looking for burn marks, where the electricity went in and where it came back out. Fire, obviously fire hazards include smoke, oxygen deficiency, high temperatures, toxic gases, and building collapse. If we're on the ambulance and we're not trained and certified to do so, then we do not go in and do any of this type of work. If you're not trained, do not do the type of job. If you are trained, make sure you guys are using the appropriate protective equipment to do the job you're at task. Motor vehicle accidents, which are very common events for EMS providers, we got to look for unstable vehicles. If they're unstable, we do not go in. If there is down power lines, we stay away until electric companies get there and turn off power. As you're approaching the vehicle and getting inside the vehicle, remember glass can be broken. When they start cutting roofs off cars, rolling dashboards, taking off doors, anything like that, there's going to be some sharp objects. Okay, so use protective gear. The last thing you want is to get caught up wearing a t-shirt in a car and you slice your arm open. Right, you got a high chance of getting tetanus and everything else too. So you want to make sure another disease is an infection. So make sure you're protected. Protective clothing and preventing injury obviously is critical to personal safety. As you can see, this guy here wearing full turnout gear, including a helmet and gloves. Become familiar with the various types from cold weather clothing. Make sure you have the 3 layers on. Turnout gear for heat, fire, sparks, and any kind of flashover. It helps protect you with the gear and thermal layers that are inside. As far as gloves, they work for heat, cold, and cuts, may reduce dexterity, but again, you're protecting your hands. There's all different types of gloves that are out there, from full structural firefighting gloves to extrication gloves. We have more dexterity in the hands to be able to move stuff around. Helmets are there for falling objects. And then boots and things like that for steel toe is preferred. But as long as you have some kind of non-mesh type boots or shoes. If you have mesh inside those, remember fluids and things that can leak through into your feet, that's the last thing you want to happen. Eye protection, ear protection, skin protection if you're outdoors in the sun for a long time, and then body armor. There's a volunteer service that's now per diem that I've been on for 22 years. They have 4 bulletproof vests that sit on the ambulance. And there's protocols and policies in place that we need to follow and we need to wear them. This became very big when we started having a lot of active shooter scenarios and situations. And then all of a sudden it became very big to get grants for. So caring for the critically ill and injured patient, let the patient know who you are and what you are doing. Approach your victim, patient. Hi, I'm here with the ambulance. I'm here to help. My name is Kevin. I'm one of the paramedics. What is your name? We'll give you the name. What's going on today? Where are you hurt? And obviously, you can see in the picture here, you can kind of see this guy's got arm injuries, hand injury, elbow. Kind of see that there. You got bleeding up on the shoulder, head injury as well. Is there anything else going on? Is there any other place that you may hurt? Let me know. Start talking to your patient. Let the patient know that you are attending to his or her immediate needs. By doing so and having that conversation with the patient, you're also checking their mental status by just talking to them. Do they have a patent airway? Are they breathing? How are they breathing? What is their circulation like? What does their skin look like? Is it pink, warm, and dry, cool, clammy, diaphoretic? Is it pale, cold, clammy? So you can tell a lot by a patient either being in shock or not in shock just by looking at the patient and seeing how they're breathing. You know, if they're tachypnic or breathing fast, then we know that potentially could be in shock or there's something else going on. If they have no clue what's going on at all, and you ask them, hey, where are you right now? Well, I'm in Florida. We're in Maine. What year is it? 1892. You know, then we know that they're not alert and oriented. That means they may have a closed head injury. It depends on what's going on. Other responses to critical patients include anxiety, pain and fear, anger and hostility, depression, dependence, guilt, mental health problems, and receiving unrelated bad news. Communicating with the critical patient, avoid sad and grim comments. Orient the patient. Be honest with them. Please do not lie to a patient. That is the worst thing you can ever do, especially if they catch you in that lie. Be honest with them. Now, don't go up there and say, you're going to die, right? Tell them, we're doing the best we can to take care of you, because that's being honest. We're doing the best we can. Doesn't mean it's going to work, but we do the best we can do. Deal with possible initial refusal of care. If the patient doesn't want to go to the hospital and you think they need to go, don't settle with it and say, oh, yeah, okay, well, they don't want to go, fine, that's fine. Just sign it off. No, you be a patient advocate and get that patient to go to the hospital. If you think they really need to go, then sell it to them. If you can't sell it to them, then contact medical control and have a physician settle that with them. Allow for hope and also locate and notify family members as needed. It's very hard when you've worked a cardiac arrest in a home for 20 minutes and then we have no signs of life and we call it in the field. Now you got to go talk to the family and let them know what happened. They may not be in the room watching. You got to be able to break the news. Injured and critically ill children, ask a responsible adult to accompany the child. A death of a child is a tragic event, so help the family in any way you can. Let the family's actions be your guide and prepare the parents. Also take care of yourself. Okay, I gotta make that as a mention. Please take care of yourself. If you have your own kids and then you go to a motor vehicle accident with the death of a child, especially right around the same age as yours, that's gonna hit you pretty hard. Maybe not initially on scene, but once you get home, once you get back to the station, you may break down. Because that really hits. It's a tragic event, and be prepared to talk to somebody if needed. As far as death and dying, death occurs quite suddenly or after a prolonged terminal illness. As an EMT, you will face death. It will happen. If it happens quite suddenly, motor vehicle accidents, massive heart attacks, and things like that, or if they have like, if they're on hospice care because they have like stage 4 cancer, or it may be a prolonged death or terminal illness. And a lot of times they put like they're on hospice or things like that, where they have do not resuscitate orders in place. There are stages of grieving: denial, anger, hostility, bargaining, depression, and then acceptance. Right? This is not going to happen in 15 minutes. This could happen over days, weeks, months. Right? Make sure that you're also seeking counseling or advising them as well, that there are other people that are out there to help them. The EMT's role in death and dying is ask how you can help. What can I do to help you? Right? They just lost their loved one. What can we do to help? Can we get you a glass of water? You know, can we make you a sandwich? Whatever it takes, we are there to help them. Reinforce reality. Be honest. And allow the patient and family to grieve. Don't be all up in their face. All right? How can I help? Oh, we're all set right now. Okay. I will be over here if you need anything. Please let me know. Now, I'm not saying stay with the family for 24 hours. Right? When it's time to go, they haven't come to you for any additional assistance, then let them know, we're going to go back in service now. We're going to go back to our station. Law enforcement will be here, and they will help you with the next step. Right? Contacting funeral homes and things like that. Law enforcement takes care of all of that with the family. Remember that as far as responding to grief, don't say, give it time, things will get better. You should never say, you should not question God's will. You have to get on with your life. You have to keep going. You can always have another child. Don't ever say that to a patient, please. You're not the only one who suffers. The living must go on. I know how you feel. I'm sorry for your loss. It's okay to be angry because it's part of the 5 stages. It must be hard to accept. That must be painful for you. Tell me how you are feeling now. If you want to cry, it's okay. People really cared for, whoever it may be. As far as stress management goes on the job, EMS is a high stress job. We deal with sick kids, sick babies, sick adults, sick grandparents. It happens. Important to know causes and how to deal with the stress. Everybody has triggers, okay? You need to understand what your triggers are and find a way to deal with them. We're going to do a general adaptation syndrome. So alarm response to stress, reaction to and resistance, recovery or exhaustion. So physiologic signs of stress would be increased respirations and heart rate. So we're going to see what they call tachycardia, tachypnea. Things are starting to move fast. You start going into what they call a sympathomimetic response. We have a sympathetic nervous system response, which would be what they call the fight or flight, because you have stress, you're getting anxious. This will also increase your blood pressure. It can also cause cool and clammy skin, dilated pupils, tense muscles. It can also increase blood glucose level as well, perspiration, and decrease blood flow to the gastrointestinal tract. Right? If you had a parasympathetic stimulation, that's where we're going to have what they call the feed or breed. Would be your gastrointestinal tract will then start increasing more flow. You start calming down, sleeping, tired, things like that. Other stressful situations, be a dangerous situation you may come in contact. You walk into a home and someone pulls a gun on you. Dangerous situation. Physical and physiological demands. The critical ill or injured patient is very stressful depending on how critically ill they are. If you walk into a home and a patient's breathing 6 times a minute, they're unresponsive, and it's not an overdose that you can fix, it's a critically ill patient. That takes a lot out of you. Patients that are actively dying in front of you, and you know there's not much more you can do to help. Or if they have a DNR, DNI in place, do not resuscitate, do not intubate in place, or the do not hospitalize and they're on hospice, let's just say it's a frequent flyer. You go there all the time. You know the family. You go there once a week, right? You've had good conversations during transport for this patient. Now it's just their time to go. That can be very stressful because you've establish a connection with that patient. Overpowering sights, smells, and sounds as well can be stressful. A multiple patient situation, 10 to 15 patients on a bus that just crashed. Angry or upset patients, family members, or bystanders. That does happen. Unpredictability and demands of EMS. Your non-critical, non-911 patients. Hospital wait times. On average, in Massachusetts, if you go to a hospital for a 911 situation to drop a patient off, I was waiting approximately 45 minutes with a patient on my stretcher waiting. The longest I ever waited was an hour and a half with a patient on my stretcher waiting to find a bed in an ER. So keep that kind of stuff in mind. You may have long hospital wait times. It can be very stressful because you want to get back in service or get back and have lunch or whatever it may be. Other acute stress reactions would be occurring during a stressful situation. We start talking about that, increased respiratory rate, increased heart rate, tense muscles. A delayed stress reaction may manifest after a stressful event, where you get back onto the station and then all of a sudden you just have that breakdown. Or you could have that cumulative stress reaction or prolonged or excessive stress, and eventually you just break down and start crying. Remember, reach out for help, right? Don't take the other alternative of suicide. Post-traumatic stress disorder, PTSD, can develop. I'm sure most of us probably have some form of it, right? So what we try to do is have what they call a critical incident stress management or stress debriefing. CISM or CISD was developed to decrease the likelihood of having PTSD. So the way these CISDs or CISMs work is they're supposed to go to a neutral location. You're not supposed to wear any form of fire department clothing. They only provide you with water and healthy snacks to eat during the situation. You leave your cell phones at the door in a basket, and you go in and you have this talk. It's an open forum. They have somebody that is there to kind of lead it and kind of lead into what's going on. This is not a critique. This is not a place where you point fingers. It's a place for you to get things off your chest and just talk. Talk about the call, talk about anything. If it opens you up, it opens you up. And that's the point behind these critical incident stress debriefings. It could take an hour, it could take an hour, it could take 4 hours. After that, if you need more help, then fire departments and EMS services usually have the ability to set you up with a counselor, to be able to talk to somebody else. If your department has a department chaplain, a lot of times they'll send you'll have a chance to go talk with your chaplain as well. So there's different opportunities that are out there to assist. Some other warning signs of stress is irritability towards coworkers, family, and friends, the inability to concentrate, difficulty sleeping, increased sleeping, or nightmares, the feelings of sadness, anxiety, or guilt, indecisiveness, loss of appetite, loss in interest in sexual activity, isolation, loss of interest in work, increased use of alcohol, and recreational drug use. So I just got asked the question as well. What is the toughest call I've ever been on, and how did I handle it after? It's hard to think. I've been on a lot of tough calls. Some of the worst ones I've been on really have been motor vehicle accidents. I've only had a couple where I've had cardiac arrest in children. I have not had one die on me yet. We've had a good return on spontaneous circulation, so positive outcomes. The youngest one I've ever done CPR on, which kind of hit me pretty hard, was a, how old were they? I want to say 16-week-old, I think it was. cardiac arrest, and CPR without any electricity got the pulses started again. We ended up transporting and made a full recovery. But I've seen like some of the tough ones were motor vehicle accidents, especially ones that involved people that I knew that I was friends with in high school. A lot of fatalities, things like that. How to deal with it is you just need to talk to somebody. If you have a significant other to talk to, find a way to relieve stress. I like going out and playing on a four-wheeler. That's one of my favorite things to do outside. So, but just, you don't forget about it, but you have to find ways to help with that. So it's a tough thing to do as far as like, how do we handle certain things? Everybody handles things a little bit differently as far as the tough calls we run into. But if you have someone that you can talk to about it and open up, don't leave things bottled inside, right? That will eventually lead to suicidal ideations and thoughts. You've got to talk to people. The burnout rate in EMS on average is 10 years. 10 years that people usually get done, especially when you start doing private EMS. I have 22 years in because I've found outlets. Do I still have some bad days? Absolutely I do. But I have more good than bad because I've found ways to relieve my stress and turn work off and try to have fun with my family. So there are ways to kind of handle it. That's how I do it. I want to come home and if I've had a bad night, if I had a really bad call, I come home and I hug my daughter. She's 6 years old. And then I get a smile back on my face again, and she's my world to me, you know? So everybody has a different way of making themselves feel better. You just got to kind of find that outlet. Hopefully that answered your question. Some physical symptoms such as chronic pain, headaches, backaches, the feeling of hopelessness. Personal reactions to difficult situations are difficult to overcome. This is normal, and every EMT must deal with these feelings. Emotional aspects of the job. So you just got to figure out it's normal. This happens. You're going to have some crappy calls out there. There are going to be calls that you worked your butt off and may have had a negative outcome. As long as you know that you can walk away from that call knowing you've done everything you possibly could to help that patient, then you've done it. Then you've done your job. Right? You did the best you possibly could. That's what helps me get through as well. I know that I did everything I possibly could to make that patient better. Many situations are stressful for everyone involved. Doesn't necessarily have to be just you. Other people may be thinking the same thing. Use extreme care in the words and actions that you do and say. You want to bring a sense of order and stability to the situation at hand. A patient's reaction is influenced by many factors. Okay? So allow the patients to express fears and concerns and transport parents with their children. Try to separate me from my daughter in the back of an ambulance. It's not going to happen. I'm going to be going with you. That's just the way it's going to work. Because I know that she's going to freak out if I'm not. And I know that she needs me there. I'm her dad, right? It's very hard to separate the two. Let's see, as far as reaction being influenced, if you walk into a home and you're a total jerk to the patient, guess what's going to happen back? Right? They're going to come back at you and they're going to be a complete jerk back. You need to have empathy and sympathy for your patients. You need to be professional and respect them. Keep in mind, remember, I mentioned this in the last class, they call you to come into a home in their worst time. They have no idea who you are, and they've got to trust you when you walk through the door. So I'm going to ask the class this question, okay? When an EMS service or fire department walks through the door, what do they expect?
Hostility,
Okay, what else? I see professionalism.
professionalism,
Yeah,
Hashing, vote.
Let me ask you this. What level of care do you think they think you guys have? What do they think you are? What level of provider do they think you are when you walk through the door? I see top-notch, high, competent.
They're probably
Perfect.
thinking everybody's a paramedic when they walk through the door, or a nurse.
Yep. Thank you, David. Thank you, Nick, for pointing that out. And why is that?
I think there's a lot of like disconnect between citizens and EMS where they don't know the different levels. So they assume everybody has gone through a lot of training to be on an ambulance service.
Yep. So I see lack of knowledge. So Joy has posted that. They're your number one priority. Let's see, Sean. A lot of people don't realize that there are differences. You know what's really hurt us the most? Television. TV has hurt us the most because when people show up in TV, and I'm going to use Chicago Fire, for example, because I love watching that show. Yeah, I know it's
We're
drama.
not all Patrick Dempsey.
Right. What level of provider care do they provide in Chicago Fire? Paramedic. Name another show that offers just EMTs. Everybody thinks we're paramedics. Doesn't matter what level you're at. When you walk through the door, oh, the paramedics are here. Well, we're not all medics. Right? So perception. Television has hurt us tremendously because they think that. The next thing they also kind of put in the reality as well, right? Volunteer EMS services. Okay. You can dispatch to a call. You're not a staffed ambulance. 5 minutes to get to the station, 15 minutes to get to the scene total, probably 20 minutes, right? But these guys have summer camps. They're up here for the summer. They come from Boston. They come from whatever, bigger cities. They expect fast response times because that's what they're used to. When they come to the country, they're not going to get that fast response time. There's not an ambulance every 5 blocks, you know? So Joy, you put a lot of good information up there as well. So these are things to think about is what they expect. So again, the patient's reaction is influenced by many factors. What took you so long to get here? All right. It is on certain situations, if it is unclear whether a true medical emergency exists, you need to contact medical control about the need to transport. If in doubt, transport the patient. Violent situations created by civil disturbances, large gatherings, potentially hostile people. That's going to be your syncopal episode or bar fight, and everybody else is in there watching you. One of the worst things to ever come in contact with is a person who went unconscious in a bar with a bunch of drunk friends around them, and all they want to do is help. That can lead to something bad. So get the patient loaded, get them into the back of the ambulance where it is safe for you to start doing more of an assessment and get them out of the bad situation. Crime scenes, do not touch stuff. Only touch what you need to touch, and you have to document chain of evidence. Domestic disputes, please don't get in the middle of it. Yeah, Emily, that's a good point too. Emily put down in the chat box, media nowadays, you have the bystanders recording you. Absolutely they do. Joy, I saw I was kind of cut off a little bit here. You put down is it important to be an excellent at what you do? Yes, very important. That's why EMS requires you have continuing education. Every 2 years, you have to have, I want to say it's like 60 hours of education for the EMT level. Sometimes I don't think that's even enough. You should be educating all the time, but you're required to have this. In the firefighting field, there is no requirement for education to recertify your Firefighter 1, Firefighter 2 certification. It's all done internally. The National Registry of Emergency Medical Technicians requires us to have continuing education every 2 years, or else we cannot renew our national. Therefore, we won't be able to renew our state license to practice. So, a lot there. So obviously, talk about this here. Know who is in command, protect you from dangers, and to provide care. Law enforcement secures the scene before your entry, or uses cover and concealment techniques. Call for additional help if needed. Do not disturb the crime scene evidence that's there. Right? Need to know who is in charge. Let's see. Hopefully, there's something here. Psych, behavioral. Yeah, there it is. This is what I was looking for. Emergencies that do not have a clear physical abuse. The cause may turn out to be physical, like hypoglycemia or head trauma, which result in aberrant behavior. So use caution with these patients. Anybody that holds an altered mental status of some sort, you need to check a blood sugar. As well. It could be something with head trauma. It could have been a fall. It could have been someone that had a head bleed from a hemorrhagic type stroke, right? So it might not be a traumatic injury, but they could have had a vessel pop in their head, causing altered mental status. Psych patients, another one you got to watch out for. Don't let them get the upper hand, right? You want to make sure of that. If they get the upper hand, then they're going to take advantage of you. All right, thanks for that, Tandra, as well. Workplace issues, cultural diversity on the job. We don't deal a lot with that up in New Hampshire and Maine, as much as you were working for like Boston EMS or the bigger cities. Each individual is different. Communicate respectively and use cultural diversity as an asset. I don't care color, race, sex, origin, transitioning. I don't care who you are, what you are. We work together as a team. EMS is a team sport. It is a team sport. It is not an I and me and only me sport at all, right? We are all here to do the same job, and that is provide exceptional patient care to the patients and the citizens that we serve in the communities that we work for, right? If you have issues with color, race, or sex, leave that stuff at home. Come to work, do your job. Your job is to work together as a team and provide care and take care of the citizens you work with. What you do in your home time, I do not have any control over, right? But when you're at work, we work together. If not, somebody will get killed. It could be a patient that has a bad outcome, or it could be a provider that's not looking out for another. Diversity is an effective way to strengthen a public safety workplace. So understand how to communicate effectively with coworkers from various backgrounds. Sexual harassment, 2 types, quid pro quo, request for sexual favors. So if you do this for me, I'll give you that promotion. To a hostile work environment for jokes and touching, etc. I understand we work in firehouses. We still have to be respectful. I understand that firehouse talk happens. Be respectful, do your job. I'll bring up one situation which went through media years ago. There was a city in Maine that had female firefighters and male firefighters all working. The male firefighters are dropping F-bombs. The female firefighters filed a complaint saying that it was sexual advancements. They brought it up, they won their case, and they can no longer swear in the firehouse. If an F-bomb is dropped, they have to go through sensitivity training now, and they potentially lose their job. That's how far that went because they made it as a hostile work environment because they didn't like the language that was being said. Again, professional. Report harassment to your supervisor immediately and take notes. Again, supervisors can't do anything to help you if we do not know what's going on. Right? Substance abuse, increased risks on the job. Right? Whether it be recreational use stuff, prescription use, drug use, whatever it may be, can lead to poor decision making. If you're becoming addicted, seek help. Okay, I hate to see anybody get in trouble. There was a paramedic. I'm not going to mention any town names or where it was located. There's a paramedic that worked for a service somewhere in the United States that worked for a hospital-based system that was giving patients saline and pocketing the fentanyl. And this was a person that was a good firefighter, right? Had an on-the-job injury, got addicted to pain meds, and was charged with 26 counts of stolen fentanyl. He lost his paramedic license, right? Lost their job, all because he had an addiction because of the injury he sustained while at work. Instead of seeking help, he chose to go the other route. There are EAPs or employee assistance programs are often available for employees that do need the help there. So again, don't put yourself in that situation. Do you feel the need that you have to start using because you have pain or because it helps you relax? Talk to somebody. Let somebody help you. All right. Suicide prevention, communal stress. Emily, I'll get to yours in 1 second. Communal stress and acute intense stress can weigh heavily on EMS providers. If you or a colleague express suicide ideations, seek professional help. I'm going to tell you guys this. Once you guys obtain an EMS license, you are considered a mandated reporter. If I called Sean and I said, Sean, you know something? I said, I've had a crappy day. I'm telling you right now, I'm going to kill myself tonight. It's going to happen. Right? I would hope that he would try to talk me out of it, but he, by law, has to report it. Because what happens if him being a mandated reporter doesn't report it and I actually do it overnight? For the record, I'm not suicidal, okay? Example.
Give you a big hug and report it.
Yeah, I get a big hug first, then you call it in.
That's exactly right.
Yeah. So that's what I'm talking. Those are things like that. You've got your mandated reports. You've got to report stuff. So, Emily, good question, by the way. Even though it's legal in Maine, because you sent it to everybody, so I'm going to talk about it. Even though it's legal in Maine, federally, it's not legal yet on a federal standpoint. With that being said, the services can also say that you can't do it. Even though it's legal, they can also limit to you what you can and can't do. There are fire departments out there in Maine that say you cannot smoke, and they will test you. It's part of their contracts if you smoke cigarettes. EMTs are drug tested, yes. So if you get if you have a sorry, Joy was texting me too at the same time. Also train of thought. So if you get involved in a motor vehicle accident, I'm going to bring up Joy's next. She wants to bring up as well. So if you get involved in a motor vehicle accident, because you're driving an emergency vehicle, you're going to get drug tested. At least the services I ever worked for, they send you for a drug test because it's a DOT issue, especially fire apparatus. So yes, you could be drug tested on that. Joy mentioned that men can be a victim of harassment as well. And it's not just female, it's males as well. So you guys got to keep that in mind too. I personally don't like people, with dirty talk at work, especially being a supervisor. I can't even allow that to happen. Oh yeah, so Sean mentioned, and I'll talk about hazing too. We're bringing up a lot of good stuff here. That's why it's taking a little bit longer than it should. So Sean says, can you actually lose your EMS license if you're found to be under the influence of marijuana or other substances? Yeah, you can. It's all up to the state medical practice board. So obviously, marijuana is not legal in New Hampshire. So if you get caught with this stuff on you, you could lose your EMS license. In Maine, with it being legal, I don't know if the state can pull your license, but you can definitely lose your job, depending on if your job has a policy in place saying that you can't do it. So just something to think about. And then Joy also mentioned something about hazing as well. If you guys get a chance, and I'm not going to go through this in detail with hazing, not a homework assignment, if you want to see a pretty sad case, type in hazing Dover, New Hampshire Fire Department and see the lawsuit case that this guy brought forward sometime. It was pretty bad hazing. So look it up sometime if you feel like looking up a hazing scenario. But Dover, New Hampshire Fire Department hazing incident. It went all the way into the courts. From captain down for this new guy. Excuse me. So elements of an injury and illness and prevention program, really management leadership. So the leadership team, management, chiefs, all need to be very aware of what's going on in workplace issues. Worker participation, you guys got to participate in the program. Hazard identification and assessment. Hazard prevention and control. Education and training, program evaluation and improvement. Fire departments have safety officers. Where I work, we have a safety committee. And we meet monthly on this. We go over different areas that we find concerns and things like that. We try to make things a little bit better for our employees in a safety aspect. So one of the things we did is we knew that there were issues with flashlights and everybody having them. So we went out and bought LED flashlights, smaller ones, for every employee that works for us. Why? Because it made it a little bit easier for them to walk around unseen. So a lot of different things, prevention strategies and programs that are out there. All right, well, apparently answer number one is B. So a disease that can be spread from person to person is known as, the answer is B, since I kind of just flashed you guys the answer. Number two, the most effective way of preventing the spread of disease is what? A, B, C, or D? Feel free to either talk it or type it in the chat box. A, it is. According to CDC, the most effective way is hand washing. Number three, while caring for a trauma patient, the EMT has blood splashed in her eyes. This is an example of what? So I see B's and D's, exposure or transmission.
Exposure.
Yep, the answer is B for an exposure. Number four, protective measures that prevent healthcare workers from coming into contact with germs are referred to as. The answer is B, standard precautions. People would think D though, because personal protective equipment. So that's the National Registry trying to trick you. They both could be right answers, but one is more right than the other. Standard precautions prevents health workers from becoming in contact with the germs. Number five, what is the second stage of response in the stress response known as the general adaptation syndrome?
I think it's exhaustion.
I see a lot of B's going up on the screen. I heard exhaustion.
E.
All right, the answer is D. The body typically reacts to stress in 3 stages: the alarm response, followed by reaction resistance, and then recovery. Number 6, a condition characterized by re-experiencing an event and over-responding to stimuli that recall the event is called what?
D.
D.
That went up quick. PTSD. Blank is the fuel to make the body run.
Food. Food is fuel.
Food.
Everybody loves food.
I thought
Food.
coffee was life.
Number 8, which stage of grieving commonly results in blame?
Anger.
B.
Yeah, a lot of B's. Number 9, placards are used on
B.
That's a good one, isn't it? I'm seeing A's, C's.
I'm saying B.
There. The answer is A. So
Oh,
we always think about placarding being on vehicles, right? We see that placard that has one of the 9 categories of hazardous materials that are on there, right? And it has a 4-digit number, which is a UN identification number, which can tell you, looking in your book, whether it be in different, I'll go over that later, but different sections of the book. In this case here, it would be the yellow section, if I remember correctly, that gives you the 4-digit number that tells you what it is. So again,
Packages
building-
also have those with hazmat.
they do. They also have other, what they call the NFPA 704, which is called the NFPA 704 Diamond, which has the heat, fuel, like the heat, oxygen, health reactivity. So basically, it's fire, health, reactivity, and we're having a moment. I can't think today, but there's 4 different colors and categories that are on there. So this is hazmat, yes. Number 10, the 5 most common hazards associated with a structural fire include all right,
I mean,
the
they're all
answer-
kind of good answers.
Yeah. Answer is A. All right, so I'm going to stop recording. Let's take 10 minutes. We're going at this now for an hour and a half, and then we'll come back and finish up chapter 3.
This conference will now be recorded.
Fire truck's driving by. All right, so we're going to cover chapter 3, medical, legal, and ethical issues. So as we have to follow our national EMS standard competencies in the medical, legal, and ethical issues to the provision of emergency care. We're going to talk about medical, legal, and ethics with consent refusal forms, confidentiality, advanced directives, tort and criminal actions, evidence preservation, and statutory responsibilities. Also mandatory reporting, which we already kind of covered a little bit. End-of-life issues and ethical principles and moral obligations. So the basic principle of emergency care is to do no further harm, right? So a healthcare provider usually avoids legal exposure if he or she acts in good faith in according to an appropriate standard of care. So the National Registry and the DOT says you will have this scope of practice. So you're going to follow the EMT scope. With that being said, now we have the EMT scope, and then we have the New Hampshire scope of practice, which gives you a little bit more that you can do. And as long as you follow that scope of practice, that standard of care, and you do things in good faith, as far as treating your patients, and you don't want to prevent any further harm, you're not going to get in any trouble. There's nothing anybody can do to you as long as you've done what you were supposed to do. And if you have any questions, medical consult. Contact the hospital and talk with a doctor. The EMT is often the first link of the chain of pre-hospital care. The EMT usually gets there first, unless you're working for a medic service. To avoid criminal and civil actions, you need to provide competent emergency medical care that conforms with our standard. So with consent is a permission to render care. So you can't just walk up to a patient and start touching them. That is assault and battery. Can't do that. A person must give consent for treatment. So you say, hey, my name is Kevin. I'm a paramedic here at the ambulance. Do you mind if we take your blood pressure? Do you mind if we assess you? If the patient is conscious and rational, he or she has the legal right to say, no, you can't touch me. I don't want to go to the hospital, and there's nothing you can do to make me go. If they are alert and oriented and they're not under arrest, then they can refuse care. Your job as a provider is to convince them to allow care. If they tell you flat out no, then don't become harassing. All right, but you want to make sure you get the point across depending on how bad the patient actually is. If they are altered mental status or unresponsive, then we start talking about implied consent, where if they were in the right state of mind, they would say, yes, please help me. Foundation of consent is decision-making capacity. Can they understand information provided? And can they make an informed choice regarding medical care? The patient autonomy is the right of the patient to make decisions about his or her health. So we need to make sure we gain that consent by asking questions. Are they alert and oriented? And you do this with every patient. Person, place, time, and events. So I usually say, what month is it? What year is it? What day of the week is it? If we had a recent holiday, what was the most recent holiday? And usually I ask, who is our current president of the United States? A lot of times they get, you want to know some of the things I get. But I know who they're talking about. So again, maybe we have to change the question around. If they tell you that it's 1964, that it's Sunday versus a Wednesday, that we're in August when really we're in December, this patient is altered. They do not have the ability to make any decisions, and therefore they lose their decision-making capacity, and we can take them to the hospital. Express consent. The patient acknowledges he or she wants you to provide care or transport. To be valid, the patient must provide informed consent. If you explain the treatment, risks, and benefits to the patient, right? You got to let them know what you're going to be doing. Blood pressures, IV sticks, well, not IV sticks for you guys, but blood pressure, medications, indications, contraindications, side effects for the patient. So if you give a patient nitroglycerin, that's one of the medications you can assist with, right? Med Control gives you orders. So, ma'am, I'm going to give you this little tablet. It's 0.4 milligrams. I'm going to give it to you sublingual under the tongue. Some of the side effects of this is it may make you feel a little dizzy. It can also cause a headache, right? This medication can also drop your blood pressure, right? Well, why is that? Because it's a vasodilator that we're giving. A nitrate's a vasodilator causing the vasculature to expand to allow more blood flow, all right? So you have to know this stuff about these medications because you're going to be giving them informed consent so they have had the treatment explained to them on what you're going to be doing. If I'm going to pull traction on someone who has a mid-shaft femur fracture, I'm going to let them know this is going to hurt like hell. But you're going to pull manual traction. We're going to place this device underneath your bottom. We're going to put you in this, what they call a hair traction splint. And we're going to pull traction on your leg to make it feel better. They're probably going to say, do whatever because it's killing me. But you've informed them of the treatment and the risks and benefits of not getting certain treatments and care. Implied consent are people who are unconscious or otherwise incapable of making an informed decision, which we already talked about. You should never be used unless there is a threat to life and limb, right? And principle of implied consent is known as the emergency doctrine, okay? So a good idea to get consent from a spouse or relative if you can first. But if they're all alone, unresponsive, you would think that in their right frame of mind, they would say, yes, please help me. We take them to the hospital. Involuntary consent applies to patients who are mentally ill, having a behavioral crisis, or developmentally delayed. So if a patient is in a behavioral crisis, they cannot make decisions on their own, mentally ill as well, all right? Obtain consent from a guardian, which is not always possible, so understand local provisions. And there are a lot of involuntary consents as well. Like Massachusetts has something called a Section 12, where the police officer can contact the courts. The courts say, yeah, you have permission to section them. That means the patient has to go to the hospital via ambulance regardless, even if it means by physical force to do so. Law enforcement obviously does the physical force. They have other weird laws like a Section 9A, which means that a police officer can have someone medically cleared by a facility while they're in police custody, and they force you to take them to a hospital. Maine has something called the blue paper. The blue paper is a court-ordered document stating the patient has to be treated at a hospital. So there are other methods of things that are out there to get patients to go. Minors and consent, parents or legal guardians give consent for minors. In some states, a minor can give their own consent depending on age and maturity. Emancipated minors, married, armed services, or parents can also give consent. Teachers and schools officials may also act in the place of the parents. Right, so a parent can't be getting a hold of. What can happen is a teacher can say, "Yep, this kid needs to go to the hospital with my consent," or a school official, school nurse, things like that. Minors and consent. If a true emergency exists and no consent is available, treat the patient, and consent is implied that the mother would want you to treat the kid, whether or father, or parent, or guardian. Forcible restraint, sometimes necessary with combative patients. Legally permissible. You want to make sure you consult medical control and may require law enforcement. If you're going to physically restrain someone to a stretcher, you want law enforcement present. They have the power to arrest. They can also help you get the patient onto the stretcher. If they're very combative, a lot of times call for ALS support and we can give sedatives to kind of help with this. We'll talk more about behavioral emergencies in detail and how to put patients on stretchers in that case as well. Know your local laws about forcible restraint. Made in New Hampshire, we carry restraints on the ambulance, soft restraints. If you have a patient handcuffed to your stretcher, right, or handcuffed in front or behind, it is required by New Hampshire protocol that the law enforcement officer has to ride in the ambulance with you. Make sure they know that. They tell you, no, we'll just follow behind. The answer is absolutely not. You need to be in the car or on handcuff.
Kevin, can I throw a question in there for you?
Yeah.
So when I was working at the jail, obviously we send inmates out all the time. And the EMTs, I'm not going to name names because I don't want to get anyone at your work in trouble, but they were okay with riding behind as long as I gave them a handcuff key to have on them. Is that not acceptable?
So that's a gray area because they have the ability to uncuff the patient.
Okay.
The reason being for law enforcement in the back is to take off the handcuffs if needed.
Right.
So I understand, like with you working there, you had to have a way to get the guy back. Right?
Yeah, no, we can only send one. So it was either they went with us following or they didn't go at all.
Right. But they had a handcuff key present. So the big purpose behind it is not for protection. It's to, if something happens to that patient, we have to be able to undo the handcuffs.
I got you.
Yep. So not a lot of law enforcement will give up handcuff keys. So But yes, if they don't have a way to release the patient from handcuffs, then technically by law, you're supposed to be in the back of the car with them or back of the truck
Okay.
with them. Yep. If restraints are used, you have to protect the patient's airway, right? So monitor the patient's respiratory status because you cannot sandwich a patient between backboards anymore. Those were the fun days. You cannot do that anymore. You cannot put pillows over their faces. You can't put them in a prone position. You can't put both hands down on the rails. One has to be above, one has to be below the head. But that way they can't move and kick, and you also have to restrain their feet as well. There's a lot of things that have to go with restraints, right? And there's specific ways things have to be done to protect yourself and protect the patient. The right to refuse treatment. Conscious alert adults with decision-making capacity have the right to refuse. They can withdraw from treatment at any time, even if the result is death or serious injury, which places a burden on the EMT to clarify the need for treatment. So what I usually do is when I have a patient who wants to refuse, I tell them, you know, the risks and benefits and things like that, so they understand what's going on. And I also tell them that any injury or illness you may have occurred while we are here or while you called could result up into including death. So if we turn around and walk out the door and you die, I am not held responsible for what just happened to you. Do you understand what I am telling you? They say, yes, I understand. Then please sign here. Have a witness sign next to it. And then you can go on your merry way. And if you turn around and walk away and they pass away because they make a wrong turn in their neck, and they sever their spinal cord, it's not our problem. We're going to do what we can to help them out, but we're not going to get sued for that because they signed a legal refuse. And we also documented that up until including death, if we walk away and you die, it does not become our issue. You cannot hold us liable. That's why it does place a burden. And it's hard to tell somebody that too. Up until including death, you understand what decision you are making. Assess the patient's ability to make an informed decision. Ask and repeat questions. Assess the patient's answers and observe the patient's behavior. If the patient appears to be confused or delusional, you cannot assume that the decision to refuse is an informed refusal. Therefore, if they're altered, they lose their decision-making capacity and they need to be transported. Any patient, suicidal patient, should not be regarded as having a normal mental capacity. If they tell you they're going to kill themselves or they're going to kill somebody else, whether it be SI or HI, so homicidal ideations or suicidal ideations, they have to go to the hospital to get a mental health evaluation. Providing treatment is a much more defensible position than failing to treat a patient. Do not endanger yourself and use the assistance of law enforcement. Right? If they make a threat, they are going to the hospital. There's no way out of it. They can say, oh, I didn't mean to do this. I didn't mean that. Unfortunately, you have to go get a mental health evaluation. Let a specialist take care of that and talk with the patient through video conference. Before you leave the scene where a patient, parent, or caregiver has refused care, encourage the individual again to allow care. Ask the individual to sign the refusal form and care. A witness is valuable in these situations we talked about, and you got to document the refusals. It is a lot better to transport a patient than obtain a refusal, right? Because you got them the definitive care at the hospital. Refusals are hard to document; they really are. And with that being said, you have a higher chance of going to court with patient refusals than you do with actual transports. Right, so make sure you document everything that happened.
Hey, Kevin, I got a quick question. What if you get a refusal during transport? Like, say they want to go and then halfway there they said, no, I changed my mind, I don't want to do it.
So if they change their mind, don't want to go to the hospital, technically you're supposed to pull over and let them out because they have that right. Other than that, it's kidnapping. However, before you pull over, you got to let the patient know. We can't pull over here. We got to find a safe place to pull over. That's part of our protocol. And then you got to notify law enforcement. Law enforcement will come to the scene and then they'll take care of the patient from there.
Okay. Thank you.
The best thing to do, though, is convince them to at least be brought to the hospital. Let them know they have the right to go against medical advice and they can walk out of the ER if they want to. But at least let them know, I want to bring you to the hospital, at least it's a safe place. Either way. Confidential information includes patient history, assessment findings, and treatment provided. You cannot release that information to anybody unless it has to do with billing, patient care, as far as providing information to the hospital staff, providing it to a paramedic if one's coming in for an intercept. But you can't go back to the firehouse to talk with the other firefighters, what you just did. They don't need to know. Now, can we break confidentiality and HIPAA in training situations in education? What do you guys think?
No.
I would say no. You can't use someone's name, but you could probably use the situation.
That is the correct answer. So we can't use name, address, phone number, but what we can use is the patient's age. We can use all the history, assessment findings, and treatments, and we can do that doing a case study, and we can present it as a case as an educational standpoint. As long as we don't disclose any demographic information other than the patient's age. Age and sex, you can do male or female. Other than that, but you can't, like Tandra said here, you can't use names, but you can use a scenario. Yeah, exactly. I do that quite often, where I'll do like an M&M round of some type with the crews that are on duty the days that I'm working, and kind of go over like a case study. Now, information generally cannot be disclosed except if the patient signs a release, which they can do, if a legal subpoena is presented, or if it is needed by billing personnel. So let's just say that the patient says to you, I want a copy of my run report. Can you just print it off and give it to them?
No.
No.
Nope. No, not at all. Thanks, Joy. So you can't just print it off and give them to anybody. If an insurance company calls you and says, we need the information, can that be given out?
Yes.
Yep. For billing personnel.
Question that, because is it our own billing department or somebody else's insurance company?
So if it's somebody else's insurance company, we still have to give it to them. But usually we defer them to our billing company, and they can work it out with our billing company itself.
Because I was wondering if that applied to confidentiality, because they're not technically in our cycle, like billing our own medical people, the nurse, the doctor, and stuff like that.
When an insurance company receives a claim, they have all of the demographic information and the codes that are procedure codes and diagnosis codes that are put on the claim form, give them an exponential amount of information. So when they call and they say, we need your run report, they want that verbal saying, hey, did your run report match what you're sending us for a bill? So it's kind of an auditing situation when they do that. They need clarification to make sure that the codes that are submitted are actually correct. Does that make sense?
Coming from a billing specialist, yes. So the other thing, what happens if a law enforcement officer shows up to your fire station and says, hey, I need a copy of that run report. Can you hand it to me?
Nope.
No. They have to subpoena it. Like, you can't just hand out run reports. So it has to be subpoenaed. And that's they'll probably get one, then get it that way. They have to do it the legit way. So don't just start handing out people's run reports. All right. So HIPAA, the Health Insurance Portability and Accountability Act of 1996, contains a section on a patient privacy now. No different than going into the hospital, they have to get consent to treat. Even though we have consent to treat, the hospital also has to gain consent to treat because it's you're turning over care. They can say, no, I'm good, I'm out of here, and they can walk right out, unless they're altered. Then they have implied consent. Strengthens privacy laws, safeguards patient confidentiality, and considers information to be protected health information, PHI. You may be legally mandated to report your findings, to release only the minimum amount of information necessary. You suspect elder or child abuse. Dog bites for the hospitals are required to report. They have to notify law enforcement if any kind of dog bite, New Hampshire wise. So what else? I lost my train of thought. So any kind of sexual abuse, rape, things like that all have to be reported. I think I hit most of them. So Joy, yes, a patient can request it, but they have to fill out a form of release. Failure to abide by provisions of HIPAA laws can result in civil or criminal action. Not only can you lose your EMS license and your national certification, you can also be fined a very large sum of money as well. Advanced directives. Advanced directives are specifies treatments that should the patient become unconscious or unable to make decisions. You have MOLS forms, you have DNR forms that resuscitate. This is an advanced directive that gives permission not to resuscitate a patient. Do not resuscitate does not mean do not treat. If they still have a pulse and they are still breathing, you still have to treat your patient until their heart stops. Okay? Now, they can have other things called do not intubate. Right? Do not intubate means, or DNI means that you cannot do any kind of advanced airway. Right? No intubation. They may say no CPAP. Okay? They don't want any kind of advanced care done. So they'll actually specify in their orders, do not apply CPAP to the patient, which means you can't use it. And at the EMT level in New Hampshire and Maine now, you can use CPAP at the EMT level. There's one called do not hospitalize. Do not hospitalize does not mean you cannot bring them to the ER. Think of DNHs as catch and release for fishing. You can catch them and bring them to the hospital, but then they cannot admit them. They have to discharge them after. Other names with living will or healthcare directives. You have to ask the homeowners. My goodness, you have to ask the patient's family if there are any advanced directives like living wills or healthcare directives. You have to have those with you for the transport. Let's just say another one, DNR must also meet the following requirements: statement of the patient's medical problems. You have to have a signature of the patient or legal guardian, and a signature of the physician or healthcare provider, and it cannot be expired. So if someone presents you with a DNR, there's no physician order on there, then you have to perform CPR. Right? Now, medical control can make the final decision. You get called to a residence for a patient who has gone into cardiac arrest. They have stage 4 cancer. They just started hospice today or started tomorrow. There is no DNR in effect. You have to resuscitate that patient. Contact medical control, let them know what's going on. The family is telling you, we don't have the DNR yet. We do not want you doing this. Call med control, run by what's going on. Say, listen, the family doesn't want it. There's stage 4 cancer. They're starting hospice tomorrow. The DNR has not been signed yet, but it's in the process. Can we discontinue resuscitation? The doctors are most likely going to tell you, yes, please stop. You might only have 2 minutes in. As long as you get orders from a physician saying to stop CPR, then you can do so. All right, does that make sense?
Yes.
Okay, you will run into this as a provider when you get called to a home because they have to call. All right, so keep that kind of stuff in mind. DNR forms are usually pink forms, and you have to have that with you if you transport the patient. All right. If they cannot provide it, then they are considered full code, which means you have to do CPR. Physician's orders for life-sustaining treatment, pulsed, or medical orders like a MOLST, explicitly describe acceptable interventions for the patient, like I mentioned before, CPAP, BiPAP, intubation, things like that. Must be signed by an authorized medical provider, and you need to contact medical control for guidance on those, on what you really want done. Some patients may have their named surrogates to make decisions for them, what they call a DPOA, or durable power of attorney for healthcare, also known as a healthcare proxy. So due to the growing number of hospice home health programs, you may face this situation. And I've come up with a lot of those in the past. Again, if you got a patient who has got dementia, I need to know who the healthcare proxy is. Who's the DPOA? Right? Now, they can say, well, I'm not, but my sister is, and she lives in California. Let's get her on the phone, because you can't make that decision for him. Okay? If the DPOA says he has no more ability to make decisions, and you actually speak with the DPOA, the paperwork says the name is Sam Smith, and you're talking to Sam Smith on the phone, they say he has to be transported, then guess what has to happen? He has to go to the hospital, right? You're going to start seeing more of this. With a growing number of hospice home health programs, you're going to come into this situation. You need to get the paperwork to prove that they are the DPOAs. Physical signs of death, a physician determines the cause of death. We do not do that, okay? Presumptive signs of death, unresponsiveness to painful stimuli, lack of cardiac pulse or heartbeat, absence of breath sounds, or no deep tendon or corneal reflexes in the eyes. With patients like this, we are allowed to call cardiac arrest in New Hampshire and Maine. You work for 20 minutes at BLS or ALS care. If there is no signs of life, we call it in the field time of death. We do not say, well, this is cardiac, this is a stroke, this is respiratory. We don't know. The medical examiner's office will take care of that for us. Unless there's obvious signs of death, which you could come into. Other presumptive signs of death, absence of eye movement, no systolic blood pressure, profound cyanosis, or lowered or decreased body temperature. This is definitive signs. This is what they call lividity, or pool and blood setting into the back. So as we roll them over, we see this. They've been down for quite some time. And as you can see, you guys see the handprint that's on there? Where we roll them over, right? That's all blood pooling inside the skin. This patient's been down for quite some time. Decapitation. So if the head is 10 feet away from the body, assume that they're dead. And we're going to end up calling it in the field. Definitive signs, decapitation, no signs of life, like that. Rigor mortis, or stiffening, or decomposition. That's when it starts to really smell in the homes. Those may be one of those triggers. If it's that bad, you may need to wear SCBAs to get inside of the home to take care of the sick people like that, or their decomposition. Yes. Keep going. Involvement depends on for medical examiner cases of the nature, scene of the death. So, I mean, obviously, if it's a 26-year-old that passed away of non-overdose, the ME is going to get involved. Presumed cardiac 90-year-old female, they're probably going to say, no, we're all set. We're not going to come in. But the medical examiner does get notified. Any dead on arrival, dead on scene calls, death without previous medical care, suicide, violent death, and poisoning, or known or suspected poisoning. Examiner cases, death from accidents will be called in for. Suspicion of a criminal act, or infant or child deaths. Every single time they have to come in for those. Organ donors are expressly wish to donate their organs. So evidence will, by information on either the organ donor card or driver's license. Your priority is to save the patient's life. Remember that organs need oxygen. Okay? Keep that in mind. If they have an organ donor card, or I'll say an organ donation on their driver's license. Other special situations would be like a medical identification insignia, bracelets, necklaces, keychains, or a card. I've seen patients have flash drives before around their neck and say, here's all my medical information. Some patients, like I said, the USB flash drive. Helpful in a patient assessment and treatment. If you have a patient with a medical alert bracelet and they're unconscious, look for one, because it could say that they're diabetic and their blood sugar could be low. So just helpful things. They also have allergy bracelets as well. So make sure you look for those. So as you can see, do not resuscitate EMS. The scope of practice outlines.
Kevin.
What was that?
That last slide where it says do not resuscitate, if somebody has a medical alert badge that says that, and I'm not sure if this is in Wisconsin, does this supersede a DNR slip signed by a physician and witnesses?
Well, I would still contact medical control first.
Okay.
Because we're required to have the pink form.
Yeah, because I had an incident the other day where we took a DNR in transport. I mean, he wasn't dead, but we took one anyways. But I saw this when I was going through the reading, and I was wondering, because when we talked about DNR, it had to be signed by a physician, witnesses, has to say what their problem is, their health problem is. And then I saw this, and it was kind of confusing.
Yeah, usually their DNRs are not too far away from them, or they might have the DNR cards, which are a lot smaller. It's like a portable card you can carry as well. And Josh, you make a good point too. People with tattoos representing their medical issues as well. You guys know about iPhones, right?
Tattooed on my chest.
You guys know about phones that have the medical ID stuff on it?
Mm-hmm.
So like on my phone, if I scroll over to the phone number, to my keypad, I can bring up my medical ID stuff information. So you can see like my medical history and all that kind of stuff, emergency contact info. And it also has the phone number built into it, so you can actually call the emergency contact, even if your phone is locked. So there are methods there. So don't forget about phones. Some people actually set those up. It could have a lot of information on it. So the scope of practice outlines the care that you're able to provide, usually defined by state laws. Medical director further defines by developing protocols and standing orders. You may have standing orders, you may have med control orders. Your protocol books are guidelines. They're guidelines on how to get you from point A to point B with a medical treatment based on what you feel is a diagnosis, based on signs and symptoms. Some orders may be standing order, where you can just do it because the doctor says you already can do it. And some may say medical control. There may be like a little picture of a phone on there. One of the ones that's medical control for the EMT level is nitroglycerin. So you can assist the patient with the patient's own nitro, but you have to call med control first before you do it. Carrying out procedures outside the scope of practice may be considered negligent or criminal offense. So if you guys decide, once you get your EMT license, to put an IV in somebody, for one, you're going to get in trouble for doing it, first of all. Second of all, if you hurt somebody doing that because you're not trained to do so, you're going to be criminally charged for that. It's also negligent to your patient. You can lose your EMS license if you've gone outside your scope of practice. A big one for me, like even for the paramedic level for myself, I am trained and certified to put in Foley catheters. Why? Because I worked in the emergency department as a paramedic where we got certified to do that underneath nursing scope. I can't do that in the field as a paramedic working on an ambulance. So you got to know what your scope of practice is. Standard of care is a manner in which you must act or behave. You need to have a good standard of care. You have to be concerned about the safety and welfare of others. I expect all of you to have a good bedside manner, which means by the patient's bedside, chair, whatever it may be professional, you need to be empathetic, sympathetic, and you need to do your job, right? Remember, these patients are scared, especially the older they are, younger they are as well for kids. Standard of care are established by a local custom and law, statutes, ordinance, administrative regulation, or case law, professional or institutional standards like AHA, CPR guidelines, or textbooks. So you'll see, like, for example, in New Hampshire protocols, say, following American Heart Association guidelines. So they adopted the American Heart Association for like advanced cardiac life support, pediatric advanced life support, BLS CPR, those types of guidelines like that. So standards imposed by states would be like Certification, Licensure, Credentialing, and Medical Practice Act. So in order to work in New Hampshire, you have to have a National Registry certification. You're going through this class to get the knowledge and skills to then take the board exams for the National Registry for EMT and skill and didactic, right? You get both of those. Once you've attained certification, okay, then you can apply for the state licensure for New Hampshire, for Maine, Massachusetts, Vermont, whatever, because you hold that certification. And then on top of that, you have to show, to renew it, credentialing. So you have to hold your different certifications, like for EMT is CPR, and then you have to show that you've met competency based on skills. And your training officer or department that you belong to can sign off on that kind of stuff. So there's a lot involved with it, not to scare anybody away, but there are things that are involved that you have to do to maintain your certification so that way you can keep your license to practice. Just because you hold a National Registry card does not mean you can treat patients until you get a license. Does that make sense? Everybody?
Yeah.
All right, cool.
Yes.
All right, duty to act. Individual responsibility to provide patient care. Once your ambulance responds to a call or once treatment has begun, you have a duty to act. If you're on duty at the station and a tone drops for a medical call, do you have a duty to act, yes or no?
Yes.
Yes.
Okay. If you are sitting at home, you're a volunteer EMT and your pager goes off, do you have a duty to act?
No.
No. If you are sitting at home as a volunteer EMT and you picked up an on-call shift, do you have a duty to act?
Yes.
Absolutely, because you are being paid to be at home or you're volunteering to be on call for that night. You are on a schedule, right? So you have a duty to act or do not. Now, because you're going to become an EMT and you're a licensed provider, some states require you to stop at motor vehicle accidents. Whether you are licensed in that state or not, because you are a medically licensed provider, you have to stop. Before you travel, know which states have that. Because you have any insignia on your vehicle, which is why I do not on my truck. If you have an insignia on your vehicle or someone knows who you are and you pass by an accident in that state, you can be held liable for not stopping and rendering aid. Vermont is one of those states. Okay. So know which state you're driving. This is why I do not have a Star of Life. I do not have a fire department license plate on my vehicle because honestly, being a paramedic, I don't want to stop because then I have to provide a higher level of care and I do not carry that kind of equipment with me. And if you show up and you're the highest level of care, you may have to transport a patient even if it's not in your response district. Just keep that kind of stuff in mind. Negligence is a failure to provide the same care that a person with similar training would provide in the same or similar situation. If you respond to a scene of a patient who is complaining of chest pain. And you know that they are they have trying to remember how to word this. You respond to a residence for a patient of a known child molester. You cannot say, oh, because they're a child molester, I'm not going to treat them. They don't deserve it. That's negligence. No, exactly right, Joy. There's a lot behind it. I'm going to put this one here out there as well. Let's say that Jeff, I'm going to pick on you, Jeff, for a minute, okay? Let's say Jeff has a restraining order against a female. All right? You're on the fire department, you're on shift, you get called to that female's house. Can you enter the premises?
No.
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 You can.
Really?
You absolutely can enter the premises because it is your job. You have a duty to act. However, you have to go there, do your job, and then you have to leave. Okay? So the thing is, I actually asked law enforcement this question in Maine EMS at the time. We had somebody that had a restraining order against one of the firefighters or EMTs. And I had to ask the question, what happens if they go to their home? They're on duty. They have a duty to act. They go, then they have to respond. But they are there to provide care, and that is it.
In that type of situation, would it be feasible to, not saying I have restraining orders out there, but if I were to go to a house that someone I was restrained from, and we know the address that we're going to, and we have a travel time, would it be ethical, I guess you could say, to call for mutual aid from another service or ambulance to meet us there so that you can remove yourself from the situation?
If you're on scene first and you delay care, you're negligent.
Yeah. But we can have them still come and then have them remove us as long as they're at the same level or higher to remove us from the situation.
And when you show up to the residence and that female patient says to you, I don't want you touching me, then you need to call for some other help to get the patient to the hospital. But you cannot not show up.
Yeah, because if they don't want us to touch them, that's refusing care. Even though they probably won't sign a refusal, we could still move out or move back until somebody else arrives. Just not leaving them because we have to have.
Correct. And as long as they tell you, I don't want you touching me. But if they don't say anything or they're unresponsive, then you have implied consent. You have to treat your patient regardless. Now, I would want a second personnel back with me just to, to kind of back me up on stuff. But you have to treat. And here's another thing too, kind of bring up in this as well. In that restraining order, it also stated they are not allowed to have weapons. Your job as an EMT could be to carry a multi-tool on your belt, could be carrying trauma shears or a knife of some sort. Okay? You are allowed to have that stuff on you when you are on duty because it's part of the gear that you carry. And this was told to me by a Maine State Trooper because I asked the question. I'm like, I don't know if they can do that or not. So I called and I spoke with one that came to the station one day and I asked him the question, can this happen? Yes or no? He said, absolutely. Let's see. Joy, you cannot decline to treat because you are covered because that would be negligent and you'd be abandoning the patient. You could lose your EMS license for it. Now, if the patient's making threats towards you that they're going to kill you if you come near them, then yes, now the scene is not safe and you back away. That's a good question though. Can you refuse to treat? And you can't. So I want to make sure I brought that kind of stuff up. Important stuff to know when you come into this. So negligence has to have all four of the following elements, not 1, 2, or 3, all four have to be present for negligence to apply. You have to have a duty to act. You have to have a breach of duty. There has to be causation and damages. Okay, that means bad outcome of a patient, whatever it may be. If all four of these apply, then you are now negligent to your patient. Negligence is very hard to prove. But don't give anybody a reason to find a reason to make it truth. Abandonment, unilateral termination of care by EMT without patient's consent or making provisions for continuing care. Right? So abandonment may take place at the scene or in an emergency department. Always obtain a signature of your patient care record. Right? If you walk into an ER and you drop a patient off and walk away without giving a report or turning care over to somebody else, that is abandonment. You've now left your patient. If an LNA or a CNA walks into the room and you give patient care report to them, that is abandonment because you are turning it over to a lower level of care than you are. EMTs are a higher level of care than an LNA and a CNA. Right? You can only turn care over to someone of equal licensure or higher. Right? So you can give care to a doctor, a DO, an MD, a PA, a registered paramedic if they work in the emergency department, nursing, or an LPN, like a licensed practical nurse. They are a higher level of care than you are, so you can. Welcome back.
So the NAs in an emergency department are similar to what we would call an EMR. If we were to classify them in
I guess if you want to consider
hierarchy.
That, yeah. But even EMRs have more training than LNAs do.
Wow.
Because remember, LNAs are not trained for emergency medicine. EMRs are. It's a different world. But EMRs also can't transport in the back of the ambulance by themselves either.
Now I'm going to be keeping out every time we go to a hospital, make sure I see RN or doctor.
Yep, absolutely. Make sure you take a look.
Yeah.
Or a medic. A medic can also take care. If you come to a New Hampshire hospital, a lot of them have medics that work in the emergency departments. And that's perfectly fine too, because it's a higher level of care.
So even though they dress the same in a hospital for the most part, they're not all the same.
That is correct. So do you guys see Joy's message there? She became a CNA when she was 15. This training is already more in depth than that class was. We're only on day 2. So keep that kind of stuff in mind. I'm not putting down CNAs or LNAs. Everybody has a job in a field to work with, and everybody plays an important part in patient care. It's who you can turn patients over to. That's the big thing. Assault and battery and kidnapping. Assault, unlawfully placing a person in fear of immediate bodily harm, like restraining somebody. You can't just restrain anybody, okay? Battery, unlawfully touching a person, providing care without consent. You have to say, do I have permission to assess you? If they tell you no, you touch them, okay? They could say it's assault and battery. Kidnapping, seizing, confining, abducting, or carrying away by force. Transporting somebody against their will. A false imprisonment charge is more likely defined as unauthorized confinement of a person. Now, if they are a psych patient, they are combative, and they made suicidal thoughts, they are now placed into custody. Therefore, law enforcement can say they're going to the hospital. All right? Whether it be them willingly going on or forcefully going on to the stretcher or calling for ALS to sedate somebody, to chemically sedate by using medications. All right? All those different options are there. But you cannot just put someone on a stretcher and take them to the hospital without their consent. Unless, like I said, unless they're in custody, then they lose their rights.
I've noticed in the state of Maine, I'm not sure if they do it in New Hampshire, but every time we have a suicidal call or they made suicidal threats, law enforcement is always called and we are always staged first.
Yep, you always stage in case that suicidal threat turned out to be like them having a knife, and we don't know if they're homicidal, you know. So law enforcement goes, clears the scene, then they have us come in for the transport. Now, sometimes law enforcement will just take the patient to the hospital because they're stable enough, they're cooperative, they're just having a bad day. They want to talk to somebody, or they may have to go by ambulance. It's the same thing with New Hampshire. Law enforcement will be called in first because of the suicidal ideation. Communication of false information that damages reputation of a person, defamation, written and or spoken. All right. It could happen with a false statement on a run report, inappropriate comments made during conversation. Your run reports need to be accurate, relevant, and factual. All right. Don't go into this. Do not put down. You can do diagnosis. I'm trying to think what I'm trying to say. Don't put down for. You don't want to put down like your thoughts on what's wrong. That could be a false statement. That makes sense?
Like staying away from opinions or interjecting your thoughts.
Yeah, it's been a long day. So yes, stay away from opinions or thoughts on what's actually going on. If you put down, I feel that the child was abused, okay, and they really weren't. You can suspect it. You can say, you can put down, DHHS notified due to formation of bruising. Let them make the determination that it was actual abuse. All right. When I was younger, when I was in high school, here's an interesting fact about this. My parents had DHHS called on them because they thought that they were beating me. They didn't think somebody thought they were beating me. That never happened, ever. But I was covered in bruises. I played football. Of course I was covered in bruises.
It was based on the suspicion or the perception of abuse.
So they were contacted, DHHS came in, interviews happened like they were supposed to do. I said, I play for the high school football team. Yeah, I'm covered in bruises on my arms. They didn't hurt me at all, So they're like, all right, no case here, we're all set. If someone called, they have to investigate it. So again, just be careful what you put down. No false statements. Be accurate, relevant, and factual. Good Samaritan laws and immunity. If you reasonably help another person, you will not be held liable for errors or omissions. Good Samaritan conditions to be met: good faith, without expectation of compensation, within your scope of training, and did not act in a grossly negligent manner. So if you're driving down the road and you see someone get hurt, you can, as long as you work within your scope of training, you can help somebody, and they can't sue you as long as you're not expecting compensation and you do it in good faith to help somebody out. They can't come after you. But again, know your laws within your state. Gross negligence, conduct that constitutes willful or reckless disregard. And there's another group of laws that grants immunity from liability to official providers. So the laws do vary. So you need to always consult with the medical director to find out. Records and reports, compile a record of all incidents involving sick or injured patients. Anytime your ambulance is dispatched, by law, you have to have a run report done. Even if you're canceled before you even get out the door, you have to do a cancellation report. Important safeguards against legal complications with this. And courts consider that action not recorded was not performed. This is why your run reports have to be very detailed. And they have to be consistent. Your reports need to have the same flow every single time you write a run report. If you're all over the place in every different report, the courts are going to consider you potentially incompetent with your job because you can't keep things consistent on what you do. All right? If a patient tells you they don't have chest pain, You have to put down patient denies chest pain. You got to put down those pertinent negatives of the patient's response, right? If you didn't document it, it never happened. So if you don't put down, you did a head-to-toe assessment, doing head, ears, eyes, nose, throat, chest, abdomen, lung sounds, equal rise and fall, pelvic exam, but assess the pelvis, checking lower extremities. And we'll get more into that in assessment. If you don't document that and you miss something, it didn't happen. Oh, I checked that. I just didn't put it down in my report. Well, obviously you didn't do it because you didn't put it down. Are you saying that you're incompetent in your job? And they're going to come after you. So like I said, incomplete or untidy reports, the evidence of poor emergency medical care. You need to have a systematic approach. And there are different methods we're going to cover in documentation. And I will send you guys the documentation manual that I made at work for all my new hires and for employees, because it's a good setup for using chart form. But it shows you in detailed documentation. The National EMS System Information System, what they call NEMSIS, provides the ability to collect, store, and share standardized EMS data and use to improve the speed and accuracy of data collection. So we use TEMSIS. At work, we use a company called, we've developed our own Easy PCR. Maine uses MEFRS. Vermont uses Siren, I think it's called. It's been a while since I've been up there. But they all have their systems that have what they call NEMSIS studies or NEMSIS programming put in there for questioning and collecting for data and whatnot. That data goes into a national database, which helps increase scope of practice. All right. So that's why it's so good for these records and reports to go into play. Most states have a reporting obligation for state mandatory requirements. Abuse of children, older persons, and others, injury during commission of a felony, drug-related incidents in childbirth. New Hampshire also has other ones like dog bites have to be reported to local authorities as well. Any patient with burns have to be notified to the fire marshal's office. So there's a lot of different reports that are out there that have to be notified. Again, all your stuff is within your local protocol, your protocol set as well.
Kevin, I have a question for you on the burns one.
Right. Yeah.
You said they have to be referred to the fire marshal's office. Now, that sounds like a dumb question, but are you talking like any kind of burns at all, or like burns from a fire?
Burns from a fire.
Okay.
And usually it won't be EMS that reports it. It'll be underneath your fire reporting. Because any kind of fire, you have to report anyways to the state. It goes to your reporting system. But any patient has been burned from a fire, so a campfire with gasoline tossed onto it, building fire with burns, chemical burns from a hazmat situation. They have to be notified that there was an injury or death from a incident regarding a IDLH or hazmat environment. Does that make sense?
Okay. Yeah. I figured that was the case. I just wanted to clarify.
Yep.
Thank you.
Yep.
I thought you were going more towards like cigarette burns, because then that would fall under abuse of children.
Absolutely. Those don't have to report to the fire marshal's office, because that's abuse. The other thing is, and for those for Maine providers, you have to, once you complete this course, you have to go on to the state website and you have to do a mandatory reporting class like every 2 years. It's either 2 years or 1 year. I'm drawing a blank right now. But you're required to also take the state mandated reporting class on top of what we're doing here.
I think mandatory reporting for us here was yearly, I think my chief said.
Yearly, okay. I can't remember if it was bi-yearly or yearly. I can't remember off the top of my head.
Yeah, because we just did it at the beginning of this year.
Yep. So Maine requires it for that, for mandated reporting. Most states have reporting obligations for attempted suicide, dog bites, communicable disease. Communicable disease, absolutely. Those have to be reported. And that will be done usually through the hospital. Now, if you have a child abuse case, or suspected abuse, I should say, don't just say, oh, I'm not going to report it because the hospital is going to. No, you have to report it also. Just make sure you notify your chief. Let them know you're going to be filing a complaint or report. Domestic violence, assaults. Sexual assault or rape, exposure to infectious disease, scene of a crime, deceased patients, and transport of patients and restraints have to be reported in some states. Ethical responsibilities, obviously ethics, philosophy of the right and wrong, moral duties and ideal professional behaviors. Morally, code of conduct affecting character, conduct, and bioethics specifically address issues that arise in the practice of healthcare. You have ethical responsibilities and conscience. So you have ethical responsibilities that have to be met. And if you don't ethically and morally take care of your patient, that can lean towards like suspension within your service, being called to the region or the state level for investigation. There are a lot of things that can happen with this kind of stuff here if you don't follow in a professional behavior. These are required to evaluate and apply ethical standards, your own and those of the profession. So be honest in reporting and keep accurate records, right? It's not so much with medications as much for you guys, but it's for higher license levels. We're dealing with controlled substances, and you have to be honest with your reporting. If you spill something, you have to document it, things like that. The EMT in court. So you can end up in court as a witness or a defendant, and the case can be either civil or criminal. This is why when you document, you have to document very well, because you may be called to court 6 years later for a case you had 6 years prior. And if you look at your own report and you did a crappy job documenting, you'll be like, what the hell? What call was this? I don't remember it at all. So describe the call, okay? Go in detail. What the house looked like. First floor, second floor patient. Size of the patient with weight. Where were they located? In bed, on the floor? How did you get them out of the house? Did you use a hover jack setup? Did you use whatever you may use, okay? Be detailed in your own reports, all right? That's going to help you when you go to a court case. Whenever called to testify, notify your supervisor, your service director, and you want to make sure that you have legal counsel, right? A lot of times the service, if you're summoned to go to court, a lot of times your service will have legal counsel, like your town attorney may come with you, or if you have whatever. As a witness, remain neutral and review run report before you go to court. Make sure you look at it, right? Because they're going to be asking you questions. And if you say something different than what your report says, right, they're going to come after you like a hawk. As a defendant, an attorney is required. All right, thanks, Dave. So every 4 years. Defenses may include statute of limitations, governmental immunity, or contributory negligence. So again, you just need to pay close attention to what you are doing with that. Let's see here. Discovery allows both sides to obtain more information through interrogations, written requests or questions, or dispositions, oral requests, or questioning that way. In most cases are settled following discovery phase during the settlement phase. If not settled, then the case can go to trial. And then damages that may be awarded, compensatory or punitive damages. So again, make sure your care follows the standard of care that is set. Following your scope of practice, you're allowed to run based on your protocol set. Document everything you've done from start to finish, even including who you gave report to at the hospital. Not just the RN, but on the RN's last name if you can get it, right? Document from start to finish everything that you did in between. Any EMT charged with a criminal offense should secure the services of a highly experienced criminal attorney immediately, all right? Even as an EMT, you should have malpractice insurance, right? And you should look at $1 million umbrella. It's not that expensive, right? There are companies out there that can give you malpractice insurance. As an EMS provider, you're not required to have it. Even as a paramedic, you're not required to have it. but it's a good thing to have to protect your family. At least get that $1 million umbrella, so that way if something happens, you are covered up to $1 million. All right. So you arrive at the scene of an older woman complaining of chest pain. In assessing her, she holds her arm out for you to take her blood pressure. This is an example of
implied.
A.
A.
Are you guys sure it's A?
It's C.
Right? So remember, implied consent is a patient who is unresponsive and you have implied consent to do it, right?
Mm-hmm.
Express consent is when they reach out, they're expressing that they want you to help. Which of the following is an example of abandonment?
E.
All right, D it is. Number 3, the unauthorized confinement of a person is called
C.
False imprisonment.
false imprisonment. Correct. Failure of the EMT to provide the same care as another EMT with the same training is called
C.
Negligence.
C. An 8-year-old boy was struck by a car. He is unconscious and is bleeding from the mouth. A police officer tells you that he is unable to contact the child's parents. You should do what?
A.
A.
Transport the patient. An advance directive is what? All right, a lot of C's. C it is. Good job. Number 7, which of the following patients is competent and can legally refuse EMS care?
C.
All right, C it is. Number 8, you're treating a patient with an apparent emotional crisis. After the patient refuses treatment, you tell him that you will call the police and have him restrained if he does not give you consent. Your actions in this case are an example of what?
Assault.
A.
That is correct. Number 9. The EMT has a legal duty to act if he or she is
B.
B it is. Number 10. Which of the following statements about records and reports is false?
That would be D.
Yep. D.
I'm seeing C's and D's. D is the correct answer. All right, let me just turn off the recording really quick.